got taken up by the Mets group. So 12 years there. बीच में 1-1.5 साल के लिए एक्शन कैंसर हॉस्पिटल में था. After that Meerut. बीच में इंटरमिटेंटली फेलोशिप, स्मॉल फेलोशिप्स, 2 हफ्ते 2 महीने, मल्टीपल प्लेसेस इन अमेरिका एंड यूरोप. तो काउंट भी आती है, maybe 15 in total. I have been to those places.
So these fellowships I think are very important because then you have a good exposure of what the other people are doing and hesitancy होती है वो it.
और एक्चुअली क्या करते हैं वो देखने को मिलता है. कॉन्फ्रेंसेस में कुछ और बोलते हैं.
हाँ, करते कुछ और है.
बात कर रहा था.
Actually,
कॉन्फ्रेंसेस में कुछ और बोलते हैं.
So I have stopped going to any conference except for my ICCon. Very selected. Either I go for any workshop for any skill enhancement or otherwise my own like very specific ICCon or something. ASI का जो भी कभी-कभी जाना का होता है. Reason
कॉन्फ्रेंसेस नेटवर्किंग के लिए और मिलने जुलने के लिए उसके लिए अच्छी रहती है.
हाँ, बिल्कुल. क्योंकि सर वहाँ पे ना बुकिश बातें ज़्यादा होती है, शो ऑफ ज़्यादा मैंने देखा कि होता है, काम की चीज़ें हम कम सी. Until unless I am really presenting something, I have some active participation. Usually I avoid going कि सिर्फ सुनने के लिए कौन जाएगा यार. Either I go present and then learn from it.
Absolutely correct.
Okay, sir. So we now formally start our program. Should we?
ठीक है. So
fine.
Yeah.
Hi Bhavna, good evening. Hello Dinesh sir, good evening sir.
Good evening.
Dinesh Agrawal sir has also joined.
Hello, good evening.
Yeah. Okay, so I hope we have improved in our networking, but still if you feel anytime anyone is having problem with the audio or the video, please let me know. Okay, fine. So hello and welcome, a very warm good evening to everyone. Welcome to our yet another session of BRENDOS. So for those who have joined us new, BRENDOS is an Breast and Endocrine Society of Western Uttar Pradesh. It's an online forum where on monthly basis we connect and we discuss about breast and endocrine related cases on alternate basis. So on even months we have breast related discussion and on odd months we have endocrine related discussion. December being an even month, now we have a breast related discussion that we will be doing today. It is very unique forum in its own sense because in this forum we pick a problem. So it's a problem based learning program. We usually pick a problem, we discuss about that case in detail. And with actual images, actual radiology, actual pathology, nuclear medicine images and whatsoever, the surgical images, the grosses, we present them in actuality with the help of radiologists, pathologists, nuclear medicine physicians, surgeons or anyone who is involved in the management of that case, so that it will give an impact, a holistic view to the participants who are attending the program. These images actually how they look like. Also, the follow-up of the patient provided to the radiologist and pathologist give them an insight how their reporting of the pathology, radiology or this nuclear scanning have an impact on the surgical outcome or the ultimate outcome of the patient. Any specialty who is ever involved in the management of that case is invited to attend the program and are actively involved in presentation of that case from their point of view, so that all the specialties they also have an idea how we all are interrelated, so that next time if the similar patient comes, we are more wise in managing such type of cases with a better understanding and interplay. This meeting is usually conducted on the last Friday of every month as a protocol, but December being the last month of the year and the New Year Eve is pending, so many of our core faculties have some family plans. To honor that, we have preponed the meeting for 1 week and we are now conducting on the second last Friday of the month. Initially, we started the meeting at 4 p.m., but 4 p.m. being very busy for most of the clinicians on their very high demand and following. You take this. हाँ, यहाँ रख लो ना, मैं भी देखूँ. On their very high demand and request, many of our elite participants, we have now changed the program time from 4 p.m. to 7 p.m. By that time, most of the clinicians usually finish their work and they are now ready to attend this program. So now from December onwards, we have changed the program to 7 p.m. Radiation therapy, we all know. If we come to today's program, okay, those who manages the breast cancer or those who have encountered breast cancer patient, maybe they are not directly involved in the management of breast cancer, but as a clinician, if someone have his or her own family member or maybe neighbor or friend having breast cancer, they must have encountered questions like regarding radiation therapy. Radiation therapy is an integral part of breast cancer management, but it is never much talked about due to many unknown reasons, but it is never much talked about. People talk about lot of discussion about surgery, lot of discussion about chemotherapy, but never radiotherapy. It has many pluses and minuses. It has many apprehensions and opportunities, but still it is never being discussed in majority of the forums related to breast cancer. In this program today, we are going to discuss about it. Reason, there are so many questions that are never being answered. Many clinicians, they also don't know about these questions, though they may not show them this to their patients, but they don't know about it. It is a hard fact and we must appreciate, we must understand this. And this forum is dedicated to provide answer to all such questions in a very simplified form. We don't go into the complexities, we don't go into very high-end studies. We just talk about the basics so that we can strengthen our foundation. Today, friends, we have gathered here to learn about the basics of radiation therapy in breast cancer. Okay, with me are my eminent guest faculties, Dr. Punita Lal ma'am. Dr. Punita Lal ma'am is a senior professor from Department of Radiation Therapy in SGPGIMS Lucknow, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. She is my mentor also. I learned a lot from her. She a very kind person. She manages such hard patients with her soft smile. Her docile nature cures majority of the patients. It is the thing which majority of the patient requires. Okay, 50% of the illness goes away with her smile only, and we used to learn a lot from her. Today also, I am expecting, and I sincerely believe that we are going to learn a lot from this forum. Our second eminent faculty is Dr. Dinesh Singh. Dr. Dinesh Singh, no, he doesn't need any introduction as such, if I can say. For those who deals with breast cancer knows him. We are very fortunate that he is now available in Meerut to provide his services. Currently, he is in associated with Valentis Cancer Hospital, and he has so many accolades in his name. Thank you very much, sir. Thank you very much, ma'am, for giving your precious time to honor our program. Our speaker for today is Dr. Shweta Agrawal. Dr. Shweta Agrawal is one of our core members, and I am very fortunate to have such a strong team, and she is one of the strong pillars. We used to discuss so many patients off the record, and I am fortunate enough that she accepted my invitation to discuss about radiation therapy, to tell something about radiation therapy to all of us. And I am very hopeful that she is going to clear most of our doubts, seconded by Punita ma'am and Dinesh sir. So we are We have a lot of things to learn today. All my friends, all the dear participants, please get up. If you have any questions, I request you all, please mute yourself. Please write your questions in the chat box. I am here to help you out. We'll take the questions after the presentation. Initially, if you want me to ask the question from your side, I'll do. If you want to ask your question yourself, please be patient. You will be given the chance to ask the question. Okay? Also, if you anyhow disconnected in between, please don't worry. Please click the link again and join us again. Please mute yourself. Only the mic of the speaker will be opened for now, following which the speakers and following which the guest faculties will have their mic open. But later on, everyone will be given the chance to discuss everything. Okay? So we can have an open forum discussion as well. So I request Dr. Shweta. Now I am sharing my screen. I am starting her presentation. And I request Dr. Shweta to please start her presentation.
Please share the screen.
Screen
The
is
full
not
screen.
full screen.
Full.
Shweta, please tell if is it visible to you?
Yes, ma'am. Yes, ma'am. It is visible.
Okay, thank you very much.
A very good evening to our guest faculty and to all the doctors who have taken out time for today's talk. I firstly thank Dr. Dinesh and Dr. Punita ma'am to be present here, and I'm really honored to be speaking in front of you all. I also thank Dr. Sudhi ma'am to give me this opportunity to speak on this very important topic, that is basics of breast radiotherapy that all a clinician needs to know. I'll try my level best to be as simple as possible and not go into technicality of the radiation. So, what is radiotherapy? Radiotherapy is a treatment of cancer by ionizing radiation, that is high energy X-rays, to control or kill malignant cells by damaging the DNA of the cell. So in 1895, W.C. Roentgen reported the discovery of X-ray, and right after 1 year, that is 1896, Emil Groove first tried radiotherapy in a breast patient which was an inoperable breast cancer. In 1901 in France, a major breakthrough took place when it was discovered that daily doses of radiation over several weeks greatly improved the patient's chance for a cure. The methods and the machines that delivered radiation therapy have steadily improved since then. At the beginning of 20th century, shortly after radiation began to be used for diagnosis and therapy, it was discovered that radiation could cause cancer as well as cure it. So, advances in radiation physics and computer technology during the last quarter of 20th century made it possible to aim the radiation more precisely. Ma'am, next slide, please. Slide, please. So this is how evolution of radiation took place, starting from 2D treatment, which were X-ray based, which is shown in picture A, and it was basically based on the bony landmarks. It then moved on to 3D CRT, which is shown in picture B, which was beginning of CT based treatment. From 3D CRT, we went on to IMRT, which is intensity modulated radiotherapy, IGRT, which is image guided radiotherapy, then BMAT, which is an arc treatment tomotherapy, and we also went to the stereotactic body radiotherapy, cyberknife treatment, and now we are in an era of MR-Linac, proton beam therapy, and etc. So I will be discussing all these modalities and all these techniques in detail in next few slides. But first of all, I would like to share that when a patient of breast cancer comes to my OPD, what are the steps that we take care of? So the first and the most important step is clinical examination. I would first want to see the file of the patient, the baseline clinical findings, that if the patient is post-op, then what was the size of the tumor before surgery, what was the location of the tumor, whether it was central or upper quadrant or middle quadrant or lower quadrants, the relation of the tumor with skin and the nipple area complex. I study the pre-op imaging, that is mammogram, MRI, PET CT in detail, which gives a lot of information to us about the location and the relation of the tumor with respective adjacent sites. Then we also look into the surgical procedure which has been done for the patient in any reconstruction or oncoplasty or any reposition of the nipple areolar complex has been done or not, which helps us when we are planning radiation, when we are contouring for the radiation, it helps us a lot. Then lastly, I would like to mention that I give a lot of time to read the histopathology report. So every line has a meaning. So we have to read the histopathology report in a detailed manner. So once we've evaluated the patient in the OPD, we move on to the radiation planning. The first step, ma'am, next slide please. The first step is immobilization and positioning. We position the patient on a specialized breastboard, which we can see that is in the blue color in the picture, which is inclined to a suitable degree so that we can get a desirable slant of the breast. We also make a mold, which is a mask, which we can see in the image, which is made up of thermoplastic sheet, which when put in hot water and cooled can take any shape we want, and it takes up a shape of the breast very well, and the patient is immobilized and do not move during the treatment. So nowadays, a lot of doctors also do a moldless treatment, like making a mold in a breast cancer patient is not compulsory. Some radiation oncologists are comfortable with mold and some are not comfortable with mold. So it is definitely a choice of the treating physician. So once we position the patient, make her comfortable, make the mold, we shift the patient to the CT scan room. Ma'am, next slide please. So the next step after doing making the mold, positioning the patient, we shift the patient to the CT scan room where we take the planning CT scan with the mold. Usually the planning CT scan is of 3 to 5 mm. It can be with or without contrast depending upon what the physician wants. And we place wire, copper wire, very thin wires on the breast, opposite breast, and the scar marks. So wires gives us an idea of a scar on the CT scan, because on the CT scan you cannot appreciate the scar, and also the surface anatomy of the breast. So after acquiring the planning CT scan, we send the patient home, and the patient is called after 1 or 2 days, and in those 1 or 2 days we take the time for target delineation and planning of the patient. Next slide please. So after we acquire the CT scan, we have the CT scan, and now the job is of the doctor to delineate the target. So what is target delineation basically? On the planning CT, we do target delineation. We make the CTV, which is clinical target volume, which is the potential microscopic disease area. In case of breast conservation surgery, CTV is the remaining whole breast, and in case of MRM, CTV is the leftover chest wall. So we also delineate the lymph nodes as per our requirement suitable to the particular case. We make the supraclav lymph nodes, internal mammary lymph nodes, and axilla. To the CTV, we add a PTV of 5 mm margin, which is planning target volume. Now, what is planning target volume? It basically accounts for the positional setup error. When we start the treatment of the patient, any miss guidance in the position is taken account by the PTV margins. Next slide, please. So for CTV delineation, we have a number of guidelines which a radiation oncologist use to mark the CTV of chest wall, breast, and all the regional lymph nodes. In the picture A, I have shown that the red marking is the CTV in the chest wall, and in the picture B, I have shown the red marking is the CTV of the whole breast. The CTV is given a 5 mm margin, which is PTV, and we can also see in the next slide, ma'am. Now, after deliberate treatment of the whole breast, the last few radiations are given to the lumpectomy cavity, which we call lumpectomy cavity boost, which we delineate by using the pre-op imagings like a